Hello and welcome to Prairie Pulse. Joining us today is Dr. Elizabeth Faust, the Senior Medical Director for Behavioral Health for Blue Cross Blue Shield of North Dakota. Dr. Faust, thanks for joining us today.
Thank you for having me.
As we get started, tell the folks a little bit about yourself and your background.
Sure. I've been at Blue Cross for about 2 years, and prior to that time I spent about a dozen years in public sector behavioral health, and then about a dozen years in private sector behavioral health. So I've kind of worked in most of my career in delivering care, and moved to Blue Cross because I'm interested in population health and designing behavioral health care that works more effectively for people.
Mm-hmm. Well, now, you're here today to talk about a couple of different things. One is, of course, Prairie Public is doing a documentary about the opioid crisis entitled The Opioid Epidemic, Seeking Solutions in North Dakota. Mm-hmm. That'll be on October the 20th at 8 p.m. And you're involved somewhat with that in that you were interviewed. Why is it important to get the word out about the opioids?
Well, I think that most people are aware of the opioid problem, and North Dakota is no different than the rest of the country. But one of the things we thought was really important at this point in time with this documentary was to talk about both the problem and the solutions, because it's easy for people to get discouraged and kind of worn down, and if they're not aware of what's working and what they can do to help our state to get through this complicated problem, it's demoralizing. And so we really wanted to use this opportunity to help mobilize everyone in terms of awareness and solutions as well as the problem.
Well, and before we go much farther, what is an opioid?
An opioid is it's a term that refers to a particular family of medications that are structured the same. So they kind of look alike, and they work in a particular part of the brain. And there's a couple things they do. They help to reduce pain, because they work in a part of the brain, or several parts of the brain that reduce pain. But they also create euphoria, or excessively good feelings. And we've arbitrarily, they're all in that family, but some of them are legal, and we use them as prescription medications. And we have other opioids which are actually illegal substances that are considered street drugs or drugs of abuse that people can be arrested and prosecuted for having.
Well, then can you talk about what are some of those differences in prescribed opioids and then the street drug opioids?
So the street drugs that people most often think about are things like heroin, which is a drug that's typically used in IV form. And then there are many prescription drugs that sometimes find their way to the street, so they're bought and sold on the black market. And those would include common names like morphine, OxyContin, oxycodone, a number of other medicines in those families. And those are given either IV or sometimes under the tongue or taken as oral pills. And they are prescribed legitimately for a number of different conditions. They're often used for surgical pain or to help people be anesthetized during surgeries and for post-operative pain and other kinds of pain conditions. But they can make their way onto what we call the street, and then they're sold to people or given away to be used by others for whom they're not prescribed. In addition to that, we have some synthetic medications. So some opioids are found in nature, like the poppy plant is where opium comes from. And then we've learned in science how to reproduce some of those and to make new compounds. So there are some synthetic opioids that are often problematic as part of this crisis. So some of the prescription medications we use are synthetics, and they're very powerful painkillers. But we now have some of those hitting the street, and a fentanyl is a term that people hear often. Fentanyl is a synthetic that's used for powerful pain reduction. There's also another cousin of that, which is called carfentanil. That's actually known also as an elephant tranquilizer because it's used for large animals, and it's extremely potent and extremely dangerous. And unfortunately, we're seeing more of particularly the carfentanil coming in from China, where it's manufactured, but fentanyl as well from outside of the country. Those are kind of coming in through the sort of drug pipelines. They're often mixed with other opioids that people purchase or get from friends, not knowing, and they're very, very potent, and that's one of the complicating factors in the crisis. Because if we have people who are already addicted to opioids, then these very powerful drugs with those vulnerable people are sort of like a forest fire in a dry forest. It's just sweeping a lot of people and creating a lot of overdose and death now.
Well, can you tell us more about the history of opioid abuse and how we got to this point?
Sure. In the very early 2000s, there was a lot of focus on management of pain and whether we were managing pain as effectively as we needed to. And so the American Pain Society created what they called the fifth vital sign to help focus the healthcare field on paying more attention to treating pain effectively. And unfortunately, there wasn't an objective measure. It's a subjective, the smiley face measure that you all always see. And around the same time, we began to have access to some very, very potent, highly strong opioid medications like OxyContin. And in the early years of those medications, it was not well understood that those medications were addictive. So there was pressure in the medical community to do a better job of managing pain. And there were some things with the Joint Commission for Hospitals in terms of raising that as a priority. And coupled with that was this, we had some new opioid medications. We've had old ones like morphine and codeine for a long, long time, but we had these new high-potency medicines. And so people started using those, believing that they were not going to be a problem for addiction, and I think we know very differently now. So all of those factors kind of convened together and kind of started out this sort of tide that we've had, which I think actually speaks to something important and that we try to talk about in our documentary, and that is that it's not a single problem, it's not a simple problem. There are a lot of factors that have led us to where we are in the problem, and it's going to require a lot of different factors to solve the problem as well.
So how bad is the problem in North Dakota?
Well, there are the estimates in the country are that we have over 2 million people who are addicted to opioids. So if you do the math from a population standpoint, probably in North Dakota there are 700 people who are in need of treatment for opioids right now. Now that doesn't seem like a lot of people, or maybe it does seem like a lot of people, but those are all people whose lives are in a downward spiral and who are at high risk to die from opioid overdose or from other complications.
Mm-hmm. Can you talk about sort of what I will call an ordinary person who might sustain an injury and then suddenly becomes an addict?
Mm-hmm. So I call this there but for the grace of God, go any one of us. It used to be, I think, thought that heroin and opioid problems were kind of sort of a problem of street people or not the middle class. And I think one of the things that's hit everyone very hard with this is that opioid dependence and the problems with that are hitting people from all walks of life. So an example of that might be a young athlete who has a sports-related injury, say a knee injury or a shoulder injury, and goes in and gets medication acutely when they're in a lot of pain, and maybe the plan is they're going to go to surgery or they're going to go to physical therapy and rehabilitation, but they're given opioids to help them manage the acute pain that they're in. And sometimes before we understood this well enough, there was a tendency, I think, to prescribe more medication than less because we didn't want people to run out. And so maybe they get a supply of medicine that's for 2 weeks worth of pain relief when in fact they maybe only need it for a few days. And so afterward, after the acute injury is over, then maybe this young person has a friend, and the friend talks about, oh, my friend gave me some, whatever this medicine was, oxycodone or whatever, and it was really good. And maybe he says, well, gosh, I've got some of that left over. And his friend says, well, gosh, I'll pay you $5 for some of that. And then people sometimes get the euphoric feeling from the medication, so they keep taking it. Sometimes people take these medicines because it feels like it relieves stress. So people start to take them regularly for either the recreational effect or stress relief, reducing anxiety, for reasons other than taking for pain. And then they develop some tolerance to that euphoric feeling, and so then they take more of it, and maybe they run out of that prescription, and maybe they kind of fudge and say to the doctor, I'm still having pain, I need some more medication. Maybe the doctor gives them another prescription because they don't know, and so they get another 30 days worth, and then maybe then they go to another doctor, and that doctor doesn't know this, and they get another supply of medication, and so they start kind of doctor shopping and going around. Or then maybe they go to their grandma's house, and their grandma has some old painkillers, and they take those out of the bathroom cabinet. And eventually maybe they start buying pills on the street. That cascade can happen.
Yeah, but are you saying then that there are times when we're over-prescribing the medication?
It appears that we are. And one example that we often think about these days is dental pain. And one of the things that we're discovering is that the procedures that are associated with prescribing in dentistry sometimes are contributing, as well as in the medical community. But for example, someone has a tooth extraction, and the doctor, it's maybe a Thursday, and the doctor wants to make sure that they get through the weekend, and they don't, because they don't have anybody covering, and so they give them extra medications. And so either that person may end up taking those, or maybe they don't. They just have them stored at home. And there's a lot of medication stored in people's cupboards who are unsuspecting. And that's an easy way for access. So people have leftover medicines after their acute pain. And I certainly wouldn't want to imply that most people take more than they need. The reality is that historically we've probably prescribed more generous supplies, again, because of that pressure that we need to do a better job of managing pain. So erring on the side of more than less, because we thought these meds were benign. And then people usually don't take all of those medications. I think everyone has either personal or family experiences where they got some pain medication, the condition got better in a few days, and then they got that pill bottle at home, and they don't know any different. They don't know that's dangerous.
Okay. Well, in the documentary that will be broadcast, there's a mental health and addiction counselor, Jennifer Reed, who has a soundbite that basically she says, why did we ever guarantee people a pain-free life? Can you comment on this?
Yeah. It really, in some ways, I don't need to. It kind of speaks for itself. I think that in our country, we expect things to be quickly fixed. I don't know about you, but I would really like it if there was a pill that made it so I didn't have to change my diet. And I think we want, and we have a great deal of faith in this country in technology and medical care, and we believe that those things can fix us. And unfortunately, that isn't always true. As people age, they have chronic conditions, and people develop, aches and pains. And we sometimes have mismatch between what we hope and expect for a pain-free life and the reality of what is likely to happen. The other thing that happens to us, I think, is that we often expect pain to go away more quickly than it really is going to go away. So.
Well, I understand there are 3 forms of medication treatment currently being used by some treatment centers. Can you go through these?
Sure. What you're referring to, I think, is what's called medication-assisted treatment. And what's important about the opioid epidemic is that it's actually almost the first time that we've had a drug epidemic that actually has medication that can treat it. Now, I say almost. because we do have medications that can help us with alcohol use problems, that help to reduce cravings and help people not relapse to drinking. But with opioids, we have some medications that work in the part of the brain where euphoria happens. And so they don't all work quite the same, but that's not really the point. The point is the medications can reduce craving so that people are not so tempted to relapse and go back to using the medications. Now, what I would say about that is that it's called medication-assisted treatment for a reason. It's not just the medication. As I said to you earlier, there is nothing simple in this epidemic. So it's medication and treatment. And what we know best about this is that medication really is kind of a pharmacological platform upon which people can begin to build recovery. So we don't ever want people to think that the use of medication should be a substitute instead of treatment, which helps people learn refusal skills and stress management and figuring out how to find new friends and relationships that are not people who are drug using and how to build a new support system for themselves. They're both important. And so it's not either or. And I think one of the things we believe is really important is that if this is truly a crisis, we can't just land on philosophy. We have to use science and data and sort of have that inform how we approach these things.
Mm-hmm. Well, yet some treatment centers are abstinence only. Mm-hmm. What's your thoughts on this?
Well, the data certainly shows us that medication-assisted treatment is a pretty important component that should probably at least be offered to individuals. And the reason that I say that is because when you compare treatment that includes medication-assisted treatment and abstinent-only treatment, you reduce the mortality by more than half from overdoses. And you double the rate at which people are able to be in recovery at a year. So those are pretty powerful statistics. Typically, if we have cancer treatments or other medication treatments that double the recovery rate or reduce the death rate by half, we say we should probably be offering these to people. I think the thing about this that's important is that really the treatment community and treatment for addiction historically grew up very separate from the medical community. And I think I always say shame on us in medicine because it actually took a long time before medicine recognized that addiction was a disease and should be treated by doctors. Back in the 50s, you couldn't get in a hospital if you had alcohol withdrawal because it wasn't believed to really be a disease. So the treatment community kind of had to grow up and figure out how to help people without the benefit of a partnership in any way. And so I think the recovery abstinence-based community is pretty strong. But what we're finding with this epidemic is it is so lethal and people are dying so frequently and to such high rates that we really have to rethink how we think about this as a both and. And so I personally would encourage us all to be open-minded about what science tells us about this. And it isn't that one has to be better than the other. I think they can inform one another and they can work really well together. As I said, that the medicine is a platform upon which people can apply those skills and learn those techniques. But I think that at the same time, it's very important to honor that people individually have a right to choose what they are comfortable with and what they are not comfortable with.
Well, is it ultimately the patient, the addict, who chooses which form of treatment to go with?
Absolutely.
Okay. Do you foresee a time when such medical treatments will be as common as diabetes medications and cancer treatments?
What I really hope is that I see a time where we don't need these treatments as much as we do now. But what I do hope, and I think we're hopeful is going to happen, is that as long as we have people who need treatment for opioid use disorders, that we get to a point where the access for that is as easy as access for diabetes care and for evidence-based cancer care. So I hope down the road we don't need as much access, but as long as we need it, I think that's our goal. The President's Commission on Opioid Use just recently made an interim statement about, what they were thinking and what direction they believe we should go. And I think all of us were very pleased because one of the things they talk about is how important it is to focus on what we think of as the supply side and the demand side. So the demand side is people needing treatment, and the supply side has to do with law enforcement and regulation and physician practice. But we really have to focus on the demand side, what people need to get treatment. And we were really pleased about that because they talked a lot in that report about the need to give people ready access so that when they're ready for treatment, they don't wait days, weeks, or months to get what they need, they get what they need when they need it. So we have a lot of work to do if we're going to get to that point.
All right. Well, let's talk about incarceration, which isn't your specialty, but can you at least address how prisoners often need sort of addiction counseling rather than prison time?
Yeah, that's a really good point. I think the lifestyle that happens to people when they become addicted, by definition, causes risks. And people do things that they might not do otherwise. So in a simplistic way, you can think about there is a criminal element because there's a lot of money to be made on selling and distributing illicit drugs. So it's not that we don't have criminals, and it's not that we don't need to treat that as a criminal behavior. But lots of people who are simply addicted do things and take risks that they wouldn't take if they were in their normal state of mind. In other words, addiction, I often say it's a disease of judgment and insight. And people who, when they were not addicted, would never have created the circumstance where they take risks and they do criminal things and they steal or they, take other risks that wind them up in jail. Those are kind of low-level criminal actions, but our system is our system. And so the more people we have who are addicted, the more people who have bad judgment and take risks and do criminal things, the more people end up in the criminal justice system. And if the only way we have of dealing with all those people is to put them in jail or prison, then we have an overrepresentation in that population of people with addiction who need treatment. Does that make sense?
Mm-hmm. Well, but what should someone do, in your opinion, if they have a friend or loved one caught in the grips of opioid abuse?
Well, the first thing I think is they should watch our documentary because I think that it talks a lot about the scope of the problem, and it talks a lot about the things that you can do and the options that people have to get help and to get educated. But there are lots of public resources, and one of the things that you can do is you can talk to the hotline, the community hotline, or you can certainly call any one of the addiction treatment facilities and ask for direction recommendations. Public health is a really great resource for people as well. So there are lots of options out there in terms of getting information and guidance. And we hope that we continue to work toward more and more of that. The Mayor's Blue Ribbon Commission here in Fargo is doing a lot of work on trying to define sort of one-stop shopping so that we can kind of mobilize all of the resources so that people can have a single point of entry that they can sort of go to and find out different opportunities, because currently it can be confusing and fragmented for people when they're trying to get help for themselves or get help for a loved one.
Mm-hmm. Well, with alcoholism, there are symptoms and warning signs. Mm-hmm. With opioid, are there symptoms and warning signs you can see?
You bet. In some ways there are overlaps. When people are using any kind of illicit substance, you can see mood changes, you can see social withdrawal. So that's not specific to any one of the substance use disorders. And the other thing I would just mention about that is people often use more than one substance at the same time. They may be having problems with alcohol and with opioids, or opioids and marijuana at the same time. So some symptoms aren't specific. But with opioids in particular, you can often see people appear excessively tired or kind of nod off and be sleepy who haven't been in the past. With children or adolescents in particular, you may see moodiness or withdrawal, loss of interest in things that they normally would be interested in, mood changes where they're evasive and secretive or sullen and withdrawn, money disappearing, unexplained absences of time or lapses, those kinds of things. And you certainly can see those in adults as well.
Yeah. Well, I wish we had more time because there's more questions, but if people want more information, where can they go? Counseling options, where can they go? Who can they contact?
Yep. So I think public health the local public health agencies are always a good option. If you Google or you look in the yellow pages, whatever your methodology is, you can look up substance use treatment or addiction treatment and find local resources. All of the treatment facilities are very happy to talk to people about and help give guidance to them. People can talk to their doctors. And so we often forget that our doctors, our primary care doctors, can be a really great resource. And as we see more and more behavioral health work closely with the doctor's office, the physician who's their primary care provider becomes always a more and more useful kind of entry point and way to get information.
Well, Dr. Lisa, we are out of time. Thanks for joining us today.
Thank you very much.
Well, that's all we have on Prairie Pulse for this week. And as always, thanks for watching.
Funding provided by the members of Prairie Public.